Hawkins talked about it as well. Remember, he's saying if your rotator cuff muscles aren't doing their job, that humerus is already going to go superior. That's the problem with half of and shoulder impairment. Start at the scapula, okay, take it more medial, and now the next one, okay, my favorite one for glenohumeral, and have you turn your head this way for me. So remember too, so again, here's apprehension, we went over that, okay, but my bicep load 2 test, resist, we're going to make a bicep curl. Anything with that? Okay, so that's the bicep load 2 test. That's your slap tear test. Okay. So the glenohumeral one, I'm not going to go into her armpit here, but is here. Okay, and so most presentations of most humeruses are going what forward, right? Right. What we're kind of constantly people are doing with the upper cross syndrome, right? Distract, externally rotate, right? Put into a position of clearance. And give it a force, right? So anterior, they say inferior on this, but it's really more of an anterior type of mobilization. I don't really have a superior vector for this, as much as the vector is more anterior to posterior and medial to lateral. Okay, I don't know if any of you have seen an adjustment like this before. But like I said, I would have a towel, okay, because, you know, for obvious reasons. And I never turn her head that way as well, okay? And I'm going to bring her just a little bit more. Patty, what I'm going to do, so I grab above the elbow, okay? I'm first of all going to distract, okay? Not too hard on here, okay? And the big thing with this is be off of the coracoid and be on the humerus, okay? And our vector is going to be this way, okay? And the force can be considerable for this, okay? But if you distract, okay? And hers is fine. I don't really feel much. I do a little bit of joint motion testing. But she can tell you that my vector is going this way. Would you agree? Mm-hmm. It's not straight back like this. Okay? So distract. Give yourself a chance for success. Okay? So I'm pulling. She can feel it. See? And then it's going to be, the set is here. This table's obviously very low for me. So it's here. I'll just do it very lightly. Here. This way. Okay? And I'm moving my whole body. Okay, so I'm not let go of her arm. Okay, does that make sense? Okay, very, very successful adjustment. Okay, but we do that second. Okay, the sternoclavicular one, turn your head this way for me. Along those lines is, so if we got it most commonly a lateral scapula, right, and anti-tilted are like this, what's the clavicle doing? So it's sitting right here, it's going to go this way, right? So the inferior and medial SC joint. Does that make sense? Right? Remember, it's incongruent. Okay? So our SC adjustment for this is that same thing. It's a distraction of the upper extremity. We're going to open it up. Okay? And then the vector, and you have to use your fleshy pisiform because it's very sensitive. This one takes a little bit of courage. Not even courage, I should say. To be delicate, I guess, for lack of a better word. But check the SC joint on your patients, okay? So same thing too. Patty would turn her head this way, and you're going to palpate. And again, she doesn't really have much going on. Is it tender at all? A lot of times it's tender on people. There's some coronary ligaments here as well. Fleshy pisiform, and this vector is more medial to lateral. So I'm again distracting the arm, and the vector is this way. Okay, a lot of times through the distraction of the entire extremity, you're going to open that joint anyway. And that's just a small little vector of a medial to lateral force. So obviously less anterior to posterior because that's going to be tender. Here and here. Okay? This way. Okay? For those of you using an arthrostim or activator or whatever, again, what's our goal? Well, we're trying to accomplish repositioning the joint as best we can. So if I have a hard time moving it and we feel it's subluxed, we'll distract, or I'll have someone just distract the arm, and I'll take my arthrostim, and I'll do very gentle, but we'll just put some forces into there in the medial to lateral format, try to get some mechanoreception stimulation. Okay? We good? You understand the misalignment pattern? That's what's most important. Lateral scapula, okay? Medial inferior sternoclavicular joint, okay? Distract, okay? Glenohumeral joint, turn it this way. Over here. This way. This way. Okay, fleshy pisiform, medial inferior aspect of the clavicle. Here, okay. For those of you,
going superior on the clavicle at all?
a little bit, yeah, a little bit superior and more medial to lateral. You'll get audibles out of the SC joint. Okay, you just got to be mellow on them. It's very sensitive. There's not a lot of tissue there. They're sensitive, but it's probably the most overlooked shoulder joint because no one wants to elicit pain. I guess is what we're trying to say. Okay, so like I said, if you're having a hard time even moving it, but it's so crucial. Remember showing that first video we saw just how much the clavicle actually moves with abduction? We often forget that this is actually part of the joint. That's the whole thing as far as how many joints are your shoulder adjustments affecting. Okay, start with the scapula, glenohumeral, SC. I don't really have an AC adjustment. I'm sure you've seen some superior, inferior ones. I don't really like that because I don't understand what it's trying to do. Anyone have an AC adjustment that they do? Yeah, you want to show it?
Standard AC.
Yeah, come on over. Go on, Eddie.
Would there ever be a reason that you would do an AC joint on the opposite side of what you found the scapula? Like with a fracture or anything like that?
An AC joint on the opposite
I mean, I'm
side?
sorry,
Okay.
SC joint.
Actually, what do you mean, yes? Yeah, we'll check both. Yeah, we'll check both. A lot of times you'll see a little prominence there, and it'll be very tender. If there is truly pathomechanics on that side, woo, that's tight, or tender, I should say. Okay, AC, Doc?
So just move these a little bit. Stay right there. Use the straddle tape, of course, just like this too. Then you guys seen? You guys seen this one?
Right.
Mm-hmm.
Yeah, so it's standard AC. Just very, stand through here, pull implant, just do a little
In distractions.
quick.
Yeah.
Quick 8 down SI. So
Did that move? See my Gotcha. Okay. That's the only one I've seen as well. I don't do it a lot.
They do a supine version too, very similar.
How would you do that?
Patient supine.
Kind of distract them.